Hello and welcome to today's Scottish Drugs Forum webinar. I'm Dave Little, CEO of SDF, and I'll be chairing today's session, which will run until no later than 2:20 past. This is the 8th in a series of webinars focusing on medication-assisted treatment standards from 1 to 10. The aim of the webinars is threefold. Firstly, to continue to raise awareness of the standards. Secondly, to highlight emerging good practice. And thirdly, to highlight challenges that remain with full implementation and how these may be addressed. Today we'll be focusing, as I've said, on MAT Standard 8, which is as follows. All people have access to independent advocacy and support for housing, welfare and income needs. People have the right to ask for a worker who will support them with any help they need with housing, welfare or income. This worker will support people when using services, make sure they get what best suits them, and they are treated fairly. A link to the full standards is provided in the chat. We've got 5 presentations today. The first is Rona Wilder, Scottish Independent Advocacy Alliance. Secondly, Niamh Eastwood and Fenella Sentence from Release. And then Freya Brock from Reach Advocacy, and finally Mary Snedden from Dundee Advocacy. Presentations will be followed by a question and answer session and a panel discussion. You can submit questions throughout the webinar through the Q&A tab on your toolbar. My colleague Austin Smith will also be monitoring the questions as they come in and will join us for the Q&A and summarize questions being asked. So let's just get started with the first speaker, Rona Wilder. Thank you, Rona.
Hi, everyone. Thank you very much for inviting me along to speak about independent advocacy. Our definition of independent advocacy is within MAT Standard 8, which we're really pleased about. So I'm going to be covering some of what makes independent advocacy important and the need for independent advocacy, looking at its connection to human rights, the different types of independent advocacy and what makes independent advocacy different than advice. So in that case, different than some of the other elements of MAT Standard 8. Next slide, please. So just quickly, who I am and who SIAA is. We're the Scottish Independent Advocacy Alliance, and we are the umbrella body for independent advocacy in Scotland. So we don't deliver independent advocacy ourselves, but our member organisations across Scotland do this. We've got around 40 member organisations, and I'll be speaking a little bit more further on in the presentation about our member organisations and the types of independent advocacy they provide. Next slide, please. So what is the need for independent advocacy in Scotland? We all know that lots of different systems that people interact with, including people that use drugs and alcohol, are not perfect. And that although there's a huge amount of work that happens in Scotland to try and include people in these systems and in these services and designing them and to make improvements to services, often a lot of this good work cannot be realised because of a lack of time or resources. This can leave people using public services struggling to get what they need. People can find it difficult at times for their voice to be heard when actions or decisions are being taken that affect their lives. Some people in society are more likely than others to be treated poorly because of barriers related to inequality or discrimination, or because of vulnerability or difficult circumstances. And this can obviously happen a lot with people that use drugs. Often people that are relying on different services have limited power because of the inequality or discrimination that they experience, or they don't have the resources to argue their case when it comes to decision making. Even when people have rights under the law, for example, people have a right to an assessment, or they would have a right to a second medical opinion. Sorry, is everything okay? Oh, okay. Sorry, someone came on camera and I thought you maybe can hear me. even when people have rights in law, for example, to an assessment or to a second medical opinion, they are often unaware of these rights and the rights may not be followed. Sometimes people can tolerate things in their lives because they don't know that they can be changed. And independent advocacy can help people to address these things, and particularly talking to them about their human rights. Next slide, please. So thinking about the principles of independent advocacy, these are within MAT Standard 8 and they are agreed by SIAA with all of our members across Scotland. So these are key principles to understand what independent advocacy is and how it can help to work with people. So independent advocacy is loyal to the people it supports and stands by their views and wishes. The work of an independent advocate is to express someone's views and wishes in different circumstances and different situations, or to support the person to express their own views and wishes. This can often be in decision-making processes. So, for example, it could be a frequent one is in a mental health tribunal. Someone has a right to an independent advocate within that setting. So an independent advocate would be there to help the person going through the tribunal to express their views and wishes. The second principle of independent advocacy is that it ensures people's voices are listened to and their views taken into account. This, again, is very important that people's voices are heard in decision-making processes. The participation process means that sometimes the outcomes of decision-making can be changed, but even more important, or as important, is that people are able to express their views, even if what happens at the end of the decision-making process isn't what they want. It's very important that their views are taken into account. And independent advocacy is the tool to help this happen. Principle 3, independent advocacy stands up to injustice, discrimination, and disempowerment. I touched a bit on this in the need for independent advocacy earlier. And next slide, please. So its link to human rights is incredibly important. We talk about independent advocates as human rights defenders, addressing issues of autonomy and choice, and supporting an individual's voice and opinions to be heard. The panel principles underpin a lot of independent advocacy practice. So this is about a participation of the person, the accountability of systems to the people that use them, non-discrimination and equality, the empowerment of people to have their voice heard and use their own voice in decision-making processes, and ensuring that services and systems abide by the law. Next slide, please. So a little bit more about independent advocacy itself. It's about speaking up for and standing alongside individuals or groups and not being influenced by the views of others. Fundamentally, it's about everyone's right to have a voice and addressing barriers and imbalances of power. Independent advocacy can support people to navigate systems and can have a preventative role and stop situations from escalating. Often there'll be situations where people are not heard at the start of the process, and if they were heard at the start, then the situation wouldn't escalate. So independent advocacy, if it is brought in early, can really be a preventative tool. Independent advocacy is especially important when groups are discriminated against and support networks are limited, and it can help people to stay engaged with services that are struggling to meet their needs. Next slide, please. So the independent advocacy organisations that are members of SIA have to be structurally, financially and psychologically independent. An independent advocacy organisation only provides independent advocacy. It doesn't provide any other services. And this can help people to gain trust in the service because it ensures that the independent advocacy itself doesn't have any power to make decisions about a person's life, about what support they might need or what resources they're going to get from services. It is there separately to make sure that the person's views are heard. Independent advocacy is about creating an equal partnership between the advocacy partner, which is what a lot of our members call the people they work with, and the independent advocates themselves. And members try to ensure that they are as free as possible from conflicts of interest to ensure this independence. Next slide, please. So there's a few different types of independent advocacy. There's lots of one-to-one advocacy, which is what MAT Standard 8 talks about more frequently. So this is about working with someone, usually short term, on a specific issue, and making sure that that person has their views heard, understands their rights, and the independent advocate can be there to make sure that the person can speak for themselves, or in some cases, the independent advocate will gather the person's views and with their agreement speak for them. There's also a few different types of individual advocacy, including peer advocacy and citizen advocacy. Citizen advocacy is a longer term relationship. We also have a number of collective advocacy groups and organisations across Scotland. These mean that collective advocacy can be about someone having a stronger collective voice, increasing networks, and contributing to structural change. Next slide, please. So it's really important for us that people understand the difference between independent advocacy and advice. We see these as mutually supportive but distinct avenues of assistance. Independent advocacy and advice are not interchangeable. They fulfill different functions and provide different levels of support. In addition, it's a fundamental tenet of independent advocacy that people accessing it are protected from undue pressure, advice, and others' agendas. So just to touch on this briefly, it is really important that when people are accessing independent advocacy, they might be signposted to advice separately, but the independent advocate would never provide advice to someone. Next slide, please. So moving on to a little bit about our member organisations. So independent advocacy itself grew up from the mental health movement in the 80s and 90s. Lots of people that were in mental health institutions found that they had a stronger voice if they spoke together, or if they had someone there that was independent from the hospital to talk to the doctors and nurses about their views. A lot of our member organisations campaigned to get independent advocacy into the Mental Health Act in 2003. And this was the first place that independent advocacy really started to grow from, because it was within the law that someone could get an independent advocate if they had a mental illness in Scotland, if they had dementia, if they had a learning disability or autism. And this was really important for growing independent advocacy. Independent advocacy has since been included in several different pieces of legislation and in some policy documents like MAT Standard 8. So there's a few groups that have a right to independent advocacy across Scotland. The strongest is under the Mental Health Act, but people under adults with incapacity legislation and people under adult support and protection can also access independent advocacy, as well as children going through the children's hearing system. And there's a few other kind of pieces of legislation as well that cover independent advocacy. So the member organisations that we have span most of the local authorities in Scotland, and they provide different types of independent advocacy. So some are collective advocacy groups, as I mentioned before, some provide citizen advocacy, and several of our members do provide independent advocacy to people that use drugs and alcohol. This is a growing part of independent advocacy, and we're really delighted that our definition of independent advocacy was included in the MAT standards, and that we'll hope to see more and more member organisations being able to provide independent advocacy to people that use drugs and alcohol. If you've got any questions for me at all, please do pop them in the chat and I can get back to you. Thank you very much. Thanks, Dave.
Thanks so much, Rona, for that introduction to advocacy. That's really helpful, I think, for the rest of our discussions. And obviously, one of your member organisations, Dundee Advocacy, will speak last. I'd now like to ask our two colleagues from Release to speak. That's Niamh Eastwood and Fenella Sentence. Over to you. Thanks.
Thank you, Dave, and thank you so much for inviting us to speak today. For those of you who don't know, I'm Executive Director of Release, and I am delighted to be joined by my fantastic colleague, Fenella Sentence, who does a lot of our drugs advocacy work at Release. So firstly, for those of you who don't know, Release is the UK Centre of Expertise on Drugs and Drug Laws. We were set up in 1967 largely to respond to the legal needs of people who were affected by the drug laws. And so at that time, we provided legal advice largely around criminal justice responses to drug possession offences and drug supply offences. Actually, really back in those days as well, we also did some social welfare support around access to abortion services. 67, it just been legalised. It was still quite hard for women to access it. So that kind of idea of providing a wider range of advice services to people was really kind of at the core of our inception. And, you know, as organizations change and grow, so did Release. And in the 1980s, we set up a legal services to address social welfare issues. And this really speaks to Matt Standard 8's point around making sure people have access to housing and income advice. So I'm going to talk a little bit about that today. And then Fen is going to talk about our drugs advocacy service, which is very much reflecting on some of the principles that Rona shared with us in the previous session. So at Release, we provide legal services in the community to people who have a history of drug dependency. And that is a group of lawyers. There are 10 on the legal team. And what we aim to do is really to make sure that people have that social safety net in place to support them, and also to make sure at the core of it that people's rights are realised. So often with the folks that we work with, because they are criminalised, because they are marginalised, they are often not given that kind of basic social safety that we would expect for others. So they are often more likely to have been turned down for benefits linked to an inability to work. They are more likely to be prevented from accessing housing through homeless services because they're not seen as having a priority need. And so we do all of that work to make sure that their cases are put forward and that their rights are realised. And how this works in practice is that we have as I said, a group of legal advisors, solicitors who attend drug treatment centres where we see clients of those centres, patients of those centres, and we really focus in on what legal support they need around housing, homelessness, access to benefits, and debt. In recent years, we've expanded it outside of drug treatment services into centres such as homeless centres and sex work projects. And I think we did that largely in recognition that lots of people who were using drugs in a dependent way weren't really accessing mainstream services. And we can have a discussion in the Q&A about why that is. But we know for a fact that 50% of people who are dying from drug-related deaths, at least in England and Wales, haven't been in contact with treatment centres for the last 5 years. And so we really wanted to get to that population. And so we've expanded out. We're now in 15 centres across London. We've just launched our virtual services in the northwest of England. And so that allows people to access legal services through online portals, which are specifically set up for that purpose. And what we do is we support about 1,000 people a year through our legal services. We make sure that people who are street homeless get access to housing. We make sure that the type of housing they are offered is housing that is suitable for their needs. So if, for example, they have pets, we make sure that we are working to get them into emergency accommodation that will provide that, considering how important those relationships are to them. We represent them at social security tribunals. And so often we hear from the Department of Work and Pensions about how our clients shouldn't be accessing welfare benefits based on an inability to work due to health conditions. And even in cases we've had them threaten to report clients to social services where their parents are trying to link their benefits to a mandation to treatment. And so what we do is really highlight what their legal rights are and why the DWP cannot act in that way. And we have successfully done that in hundreds of cases in recent years, and we have a success rate of nearly 100%. And I suppose just I'll finish off on why release. I think for our clients, so many of them accessing mainstream legal services in the community, they feel rightly or wrongly that they will be stigmatized because of their drug use. They feel that they will have to disclose their drug use, whereas when we are in those centres, it is a given. It's often not part of the conversation. And so they're much more able to come forward to our services, and they are also much more aware of the fact that our lawyers will be well trained in the issues that they face, and that we campaign more broadly for their rights in political and policy spheres. And so I will hand over to Fenella to talk about our drug advocacy services.
Yeah, so I'm Fenella, so I'm one of the advocates at Release. So most of the advocacy work I do is in drug treatment settings. So I'm just going to talk, I'm just checking what the time is, yeah. What the kind of purpose of advocacy is at Release as we see it, some of the kind of practical support that I offer day to day, and then just kind of hopefully talk about 2 different case studies which exemplify some of the reasons that independent advocacy is so important in a drug treatment setting. So one of the kind of key reasons that advocacy is really important at Release is that we're trying to offer people immediate intervention in often quite emergency or really, really stressful situations. So whether that's they've been returned to supervised consumption and they're really worried about the spiraling effect on employment, or they've had a sudden change to their medication. So that's sort of the double-edged sword of advocacy, is that on the one hand, there isn't really a set process that you can follow, and that can be quite stressful for the client and for the worker. On the other hand, it enables advocacy to actually set its own pace in terms of what it wants to do. So we try and secure people to have immediate changes in their life, where something like legal action might be a much lengthier process. So what that means day to day for me in my work is just kind of being really present with people in their treatment and trying to get them a fast outcome. So going to appointments with them, escalating complaints for them if it has to happen, and basically just being present to facilitate them to speak for themselves. So I want to talk about 2 cases which for me have really exemplified the issues I've seen, and that's questions around who is at risk in treatment between a patient and a prescriber, and also questions around consent. So it's worth saying that the bone of contention in these cases isn't a kind of in-depth medical argument. I'm not from a medical background. Actually, what's kind of being argued for is for people to adhere to the basic tenets of right-based treatment. So often these people are excluded from conversations about their treatment. They're not involved or consenting to decisions, and often they don't even know that the decision is going to be made. So unfortunately, with these cases where people are coming to us, that's usually the stage we're actually at. And what I've noticed is part of that relates to this idea that OST particularly is usually couched in terms of a prescriber doing a kind of generous favour to the patient, rather than adhering to actually what that patient's right is in treatment. And that links to questions about consent and also about risk. So what I hope the 2 cases I'll talk about show is that risk is actually spoken about as a professional risk for the prescriber rather than the personal risk for the patient. So the first case was involving quite a young person in their mid-20s, and they've been told multiple reasons that they couldn't be prescribed OST, and that was what led them to reach out to Release. And some of those reasons were they were told that they were too young, they were told that the specific opiates that they were using weren't justified grounds to be prescribed OST. And then ultimately, one piece of information that fed back to them, which never should have fed back to them, was the concern of the prescriber, which was fear that they were going to lose their medical license. So aside from the sort of the fact that that's not really the patient's worry to consider, it also shows that the sort of risk profile within that, the risk there being considered as a professional risk rather than the risk of the actual person whose drug use they felt was getting more and more risky the longer they stayed out of treatment. So they had moved from using opiates around sort of oxycodone to heroin, and that was really concerning for them. They felt less experienced in that. They weren't really in a community of users of heroin, so they were much less confident using it. And what was interesting about that case also was that that person at the very beginning had signaled very clearly to the service, I'm concerned my drug use is going to get riskier, and that hadn't been taken seriously. So it's about risk, but it's also about the undervaluing of a patient's self-knowledge about what's going to happen in their treatment. And that's something that I see over and over, is this kind of clashing of so-called objective medical knowledge compared to people's individual knowledge about their own kind of bodies and choices. And that really links to what Rona's saying about a human rights sort of advocacy, being a defender of human rights. And then in that case, the sort of purpose of advocacy was to try and really break into the mentality of the service then, which was saying that sort of doing nothing was less risky than doing something. So it was kind of constantly reminding the service, this is the risk that is existing and this is what you need to do about it. And then in the second case, there was some that I want to talk about, there was some similar issues around risk. So again, risk being conceptualized as a professional risk to the prescriber rather than a personal risk to the person. And then in addition to that, what was most concerning there was a practice of routinely making decisions without the prior consent of the patient. And that manifested in a number of ways, the most extreme being the patient turning up at the pharmacy to suddenly discover their prescription had changed. But it also manifested in quite sort of emotionally insidious ways in appointments, which was sort of is distressing and traumatic in its own way. So something I noticed was that the prescriber would often talk about decisions that hadn't been made with the involvement of the patient in the past tense or in the plural. So saying, we already agreed on this, or we made this decision. And for this was a slightly older patient who was under considerable stress. There's a genuine anxiety there that they are misremembering events. So their advocacy has worked well, kind of to be sort of in the background, being slightly quieter and actually just acting as a witness for this person. So being able to reassure them and tell them, no, you are remembering this correctly. This is what happened. And then giving them that space to speak for themselves. So sort of what I'd want to finish on is the most important sort of lesson I've learned in the advocacy work I've done is that more often than not, all you need to do is create a space for somebody else to speak for themselves, and they will argue better than you ever can, really, for what they need. Yeah, I think that's everything I have to say.
That's great. Thanks so much for both of you, and some really important points there to finish that presentation on. If I can now ask Freya Brock to come on camera and speak. Thanks, Freya.
Thanks. But yeah, no, just to say, yeah, thanks for having me. And also, it's just been really interesting listening to Niamh and Fenella speak there. Kind of following on from what they were saying about kind of rights being realised. I guess our part in Reach advocacy is to kind of do that education and training point for people to try and, you know, upskill everyone on what their human rights are, as well as kind of upskill people in using a kind of rights-based approach within advocacy as well, to try and make sure that that accountability that you were speaking of there is generated in Scotland, which we've not really seen so far, with these kind of stark increases in health inequality, and especially around drug-related deaths, which we're speaking about today. So what I'm kind of going to look at today is kind of some reflections on the MAT standards and the work that we've been doing with Public Health Scotland in kind of raising awareness of the MAT standards, and especially MAT 8, but also kind of dip into our training at Reach Advocacy and what that can bring, hopefully. So obviously we're focusing on MAT 8 today, which states that people have the right to ask for a worker who will support them with any help they need with housing, welfare, income. This worker will support people when using services, make sure they get what best suits them, and that they are treated fairly. So kind of on a personal point, I think that this standard really underpins the realisation of all other standards identified in MAT, such as same-day access, informed choice, assertive outreach, etc. We know, especially when it comes to individuals' care and treatment, that people feel particularly vulnerable as their care are in the hands of others. This means that often patients feel really uneasy about challenging services when they're not meeting their needs for fear their quality of care changes. So due to this, accountability can be difficult to generate, and especially, Fenella was talking about it there, for people, in these situations, they particularly feel very vulnerable about doing that, and actually just creating that space where you can kind of back up, yeah, that's what happened and things like that. They're best suited to kind of argue their rights there. But this is kind of what we're talking about. This is why advocacy is so important. And I think for me, in terms of the MAT standards, it can't be seen as an isolated standard, but rather that practice or that right which must be in place to ensure that all other standards are realised in practice. So in addition to advocacy being an underpinning practice for embedding the MAT standards, at Reach Advocacy, we also believe that they need to be couched within this wider human rights-based approach. And I think we can all agree that the MAT standards are a really positive step forward in tackling this national health crisis that we're seeing, but maybe unsurprisingly, they aren't anything new. And in fact, a lot of the standards can be found in existing clinical guidance, such as the Drug Misuse and Dependence UK guidance on clinical management, as well as national guidance from NICE as well, which really indicates, again, this lack of accountability within Scotland for services to uphold the rights of individuals. And, despite that clinical guidance already being there, we can see that, that drug deaths have really continued to rise, dramatically since 2010. So as great as they are, and I think, again, we've kind of talked on it with the previous speakers, they kind of need to be couched in the kind of legislative instruments to kind of give it a backbone for challenging duty bearers if they're not meeting those rights for people. And at Reach Advocacy, we do particular training on the Human Rights Act 1998 and the Equalities Act 2010, until the International Covenant on Economic, Social and Cultural Rights is kind of directly incorporated into law. We kind of go through these legislative instruments to try and get people's rights met, and especially that right to health. But we're really pleased to see the Scottish Government committing to taking a human rights-based approach to design and implementation within policy and practice. And this has been reflected in sort of the First Minister's speech, drug policy, Angela Constance's speech, and reports such as the final Drug Death Task Force report, the National Mission, Public Health Scotland have talked about it in their kind of MAP benchmarking reports. So our job, I guess, we feel, is to ensure that that human rights-based approach doesn't become just a buzzword in reports, and that the MAT standards don't get left on the shelf, but rather we kind of work through education and training to try and ensure that these are embedded on the ground to kind of make rights real. Yeah, and I guess to ensure that, we're actually generating that accountability and we can actually enforce change with the rise in drug-related deaths. So just to kind of talk a little bit about Reach and the training that we do then, for those of you who don't know, Reach is a third sector charity organisation founded by Jed Brady and Derek McCabe, who was meant to be here, but he's put his apologies in. They started the organisation because through their own lived experience of substance use and mental health, they found services which were supposed to help us live long and healthy lives were difficult to access and often didn't meet the needs of the very patients it was designed for. So back then, Jed and Derek sought to kind of combat a complex health system by looking to be trained in their human rights and advocacy to try and make sure that their rights were heard and that they were communicating them effectively to services. At the time, they didn't actually find any training that was available to them. And so they worked with SQA to create their own accredited training, which we deliver today. That training in a rights-based approach to advocacy is accredited at SCQF level 7 and is quality assured by the SQA. This is a 12 to 14-week course which explores topics such as the social context and root problems surrounding and contributing to health inequalities in the UK, and especially to drug-related deaths. Within this module, we look at the definition of substance use disorder identified by the International Classification of Diseases, which identifies developmental, biological, neuropsychological and psychological factors as contributors to the health condition. We then explore these factors to allow participants to understand the causes of substance use disorder, before looking at how a human rights-based approach can start to address these poor quality of life outcomes we're witnessing. Initially, we explore these kind of developmental factors by looking at the environment people in Scotland and the UK have experienced over the last 20 years. We discussed this through reports such as the Philip Alston report, which was published in 2018 on poverty. We look at life expectancy statistics, which have gone down by 2 years in the last year. We also look at reports such as the Michael Marmot report as well on health inequality. As well as that kind of social context, we touch on biological, neuropsychological and psychological factors of substance use disorder by exploring adverse childhood experiences, trauma, and how this can manifest itself into poorer quality of life outcomes for people if we don't interject in people's lives with trauma-informed services and care. Furthermore, we discuss the effects of this trauma untreated through the NHS Education for Scotland reports. And some of these percentages I just want to bring up because I think they're quite kind of poignant. But the ones that they identify is that, 75% of women and men attending substance use services, for instance, report abuse and trauma in their lives. Among people in prison, studies have found 94% of people report a history of trauma. And in inpatient mental health services, 60% of women and 50% of men report being sexually or physically abused in childhood. So that standard 10 trauma-informed care is really important. But obviously, we're not going to get there until we generate that accountability through advocacy. So in addition to this, within that kind of social context module, we look at how drug behaviour has changed in the last 20 years to polydrug use. And we know from the most recent report that out of 93% of all drug-related deaths, more than one substance was found present in the body. So with the rise of drugs such as tisalam, benzodiazepine, pregabalin, gabapentin, and injecting cocaine, we explore if the care and treatment is really reflective of this change in drug use behaviour through the ICD-11 and the Drug Misuse and Dependence Guidelines on Clinical Management. In this section, we also bring in the NICE guidelines on dual diagnosis in Scotland. And we do this because Scotland haven't produced guidance on this. And I think this needs to take priority. As from our workshops, we know that many people who have a substance use disorder are unable to receive mental health treatment, even despite national guidance saying that individuals should not be excluded from receiving mental health support. Again, so in this second module, we cover the foundation of a human rights-based approach, which is human rights legislation, with a specific focus on the International Covenant on Economic, Social and Cultural Rights. And until that's directly incorporated, like I say, we kind of go through the lens of the Human Rights Act 1998 and the Equalities Act 2010. And within this section, we introduce candidates to the terms duty bearer and rights holder and the different obligations the two roles include. In addition to this, candidates on the course learn how to apply this knowledge to different case scenarios using human rights-based frameworks, including the FAIR model and the panel principles, which was touched on earlier. I think this is probably the most important part of the training. It's about taking kind of rights off the page and making them realised in working practice and personal practice. So it allows a kind of step-by-step, very pragmatic framework to work from that everyone can learn. And so it means that these kind of tangible frameworks ensure that rights-based approach doesn't just become this kind of buzzword that we write in reports saying, yeah, we work from a rights-based approach, but it actually allows a standard in which we can measure from, and we can see if people are truly working from a rights-based approach or not. Another key topic in this course is obviously advocacy as a practice. And within this, we look at the importance of principles and standards as identified by SIA. But as well as that, we also take focus on the QPM from down south. And we think it's important for candidates to be aware of a broad scope of standards and principles to ensure best practice overall. And finally, kind of in addition to this, these kind of key modules, in this course, we also look at report writing, Harvard referencing, and completing an STQA. Through developing a portfolio of human rights-based case studies derived from candidates' personal and work experience, candidates learn how to reflect on their own practices and develop their advocacy abilities through the implementation of these rights-based frameworks. And then again, just to say, upon graduation, candidates are fully qualified in rights-based advocacy. So I kind of chatted a lot about our main course that we deliver, but as well as that, as part of the kind of government's national mission, we've been working with Public Health Scotland to raise awareness of the MAT standards. This awareness raising project started at the beginning of 2021 and is currently ongoing. Within this time, we've delivered workshops in 16 different localities across Scotland and have had an average of 600 participants attend these workshops. To ensure effective implementation of MAT within a human rights-based approach, we push to deliver these workshops to a cross-population of participants from statutory and non-statutory organisations, lived and living experience individuals and policymakers to promote joined-up working between policy, design and practice of services. This has been a really kind of interesting project as we've been able to collect a lot of experiential data from participants about the challenges of implementing MAT, as well as kind of points of good practice. And here at Reach, we've started to be able to kind of map out these challenges and good practice across Scotland. Some of the common themes which I'd like to share with you today, kind of overall, participants were unaware of their human rights and how to enact them. That includes staff, as well as kind of everyone, policymakers as well. In every locality, pretty much, participants have fed back that getting mental health support has been near impossible for individuals with a substance use disorder, as practitioners will not work with an individual until they are free from using substances. And finally, the majority of GPs in localities still will not prescribe for patients with a substance use disorder. I think from these overall reflections, we kind of get a little flavour of we've got a long way to go with MAT. And one thing as well that's discussed as well is obviously advocacy and MAT 8. And to share some of the reflections there as well, candidates have said advocacy appears exclusionary. So often frontline staff who participate in the workshops say that feedback that they don't know who is eligible to advocacy. They said that there's an overall perception that individuals are only able to access advocacy if they are detained under the Mental Health Care and Treatment Act or adult support and protection. Furthermore, they explained that within different localities, advocacy services are funded to work with different population groups, again creating a barrier and confusion as to who's eligible. The second kind of main reflection is that there's a lack of information about advocacy. Participants fed back that they didn't really have an understanding of what advocacy was and who it was for. So often they didn't relay this information to patients about advocacy, or they were reluctant to refer people on as they weren't sure if the service was appropriate or not. And then finally, many advocacy workers who participate in the workshop said that advocacy needs to be offered sooner to individuals before they're reaching crisis point. They explained that taking a preventative approach with advocacy would see better outcomes for the individual. And one patient suggested, which I thought was quite good, that there should be an opt-out of advocacy when someone kind of accesses a service instead of an opt-in. So with those reflections, some kind of points that I think are important to take forward in the discussions of MAT 8 and advocacy is, firstly, we need to ensure that advocacy is afforded to everyone who needs it. Taking a human rights-based approach, especially kind of couching it in the Human Rights Act, Article 6, the right to a fair trial, the right to representation with those civil and criminal cases, and Article 13 as well, the right to remedy, are kind of points that we can take forward to make sure that advocacy is made more available to kind of all populations or whoever would like it, as opposed to kind of certain population groups, because it can make it quite exclusionary and kind of confusing about who can have advocacy, basically. Secondly, feedback has informed us that advocacy standards and practice differ in different localities across Scotland, and we can't continue a kind of postcode lottery when it comes to advocacy, but therefore we need to kind of ensure that there's kind of standardised training which is adopted across the board. And thirdly, we must ensure that services have clear information about what advocacy is and ensure that information is communicated to individuals accessing services. So just kind of some reflections on all of that and the MAT standards in general. As part of the training that we do, at Reach, often my colleague Ariane and I bring out kind of old reports to measure how far Scotland has come at tackling the issues that we're discussing today. One of these reports is the Mind the Gaps report, which was published almost 20 years ago in 2003. Within this report, which looks at the dual diagnosis of substance use disorder and mental health, it produced the same recommendations which we're talking about today. So working towards social inclusion, towards a successful and sustainable economy with good employment prospects, training experiences and opportunities, towards reducing homelessness, towards targeted provision of housing support services, and towards creating equitable access to the range of care service, regardless of boundaries, and designed to meet the needs of people as clients and our patients. So a lot of these recommendations in the Mind the Gaps report are reflected in the wraparound care that the MAT standards are producing today. And I think overall, we're talking about kind of the social determinants of health that need to be met for people before we're going to see these kind of poor quality of life outcomes change. However, we've not seen that. And over the last 20 years, we've seen an increase in poor quality of life outcomes, and we've seen a stark rise in drug-related deaths, which kind of highlights that we have a real lack of accountability in Scotland. We're quite good at bringing out good pieces of legislation, which appear progressive, but actually getting them embedded on the ground it appears to be a much more difficult thing. And obviously through education and training and advocacy, I think there's one way we can tackle that. But we're really kind of, glad and in line with the Scottish Government, we welcome the renewed focus on a rights-based approach, and education and training in a human rights-based approach will be really important, especially as the Scottish Government are trying to bring in other pieces of international legislation, which is going to protect our rights to health further, such as the International Covenant on Economic, Social and Cultural Rights, the rights of women, the rights of children, the rights of people with disabilities, and race relations rights. I know the current government are trying to implement all of these, so a kind of renewed focus on human rights is really, really important at this time. But overall, I think the MAT standards are great, but they cannot be left on an overpopulated shelf at this point. And therefore, we must ensure that people know and can claim their rights. And advocacy is one way that we can definitely do that. And with all the kind of, everyone who's speaking today, I'm sure that's the kind of renewed focus that we all need. Thank you.
Thanks so much, Freya, for that. A lot of issues there that you raised, and obviously the question of accountability, I'm sure we'll come back to, and also for reminding me of that report that we often quote as well, the Mind the Gaps one, which I was involved with, I have to say. So thanks for that historical reference as well, and I would agree with you that we haven't come certainly far enough in all of those issues, and actually we're discussing the MAT Standard 9 at the next webinar, and the previous one we also obviously discussed the lack of GP involvement as well. So thanks for that, Freya. We'll come back to you with the panel at the end. If I can now invite our final speaker, Mary Snedden from Dundee Advocacy. Thanks, Mary.
Afternoon, everybody. I'm Mary Snedden. I'm the manager at Dundee Independent Advocacy Support. We've been providing independent advocacy for 25 years plus to a wide range of mental health, learning disability, physical disability, dementia, etc. And although we've never previously supported people specific as substance use, we have had some experience, although limited. In 2020, we were recommended by our commissioners in the Dundee Health and Social Care Partnership to our local ADP to submit a bid for a tested change, to have specific independent advocacy workers to support people who were experiencing substance use challenges and their families. We were successful and after and received 2 years funding for a 21-hour post, and that started in February 2021. After the initial period of raising awareness and the tested change post, making connections, it did take a wee while for us to find our feet in the substance use arena. We did start to see numerous referrals coming in, mainly from statutory services, but very quickly that shifted and we started to see a lot of self-referrals. word of mouth had got around that having an independent advocate can mean that you have a say in your care and treatment and your life choices. And many of the substance user referrals that we had received said that they had never actually ever experienced that. What particular difference does an independent advocacy have for people with substance use? Well, I think each of the speakers have actually touched on that today. It is about being involved in making your own life choices, know what your rights are, and there's so much of it about. It's really difficult to navigate your way through that, and even as professionals we find it difficult. So it must be really difficult for somebody off the street that really doesn't know a lot about in this area. So many of the referrals we received felt nobody was listening to them. Decisions have been made without their voice being heard, and many still experience stigma even within statutory services. I guess the difference is because we're independent, we're not aligned to any other services, people actually do find it that bit easier to gain that level of trust with us, which is so important. And our advocacy workers say that until they have that trusted relationship, we don't actually make a lot of inroads into the support that they need. In the majority of referrals that we've had over that period of time, we have seen increased engagement with a wide range of services. It allows that partner to make that, we call the people we support partners, to make an informed choice. And some have helped to seek recovery, a recovery pathway. Others have not, and we can help to support them in other ways to make sure that they're in a more safe environment. One of the things is that they entrust their story to us, and I really get quite distraught and traumatized by the fact they need to regularly repeat that story time and time again. It invokes trauma for them, and it's often a barrier to engaging with services. And that's one of the real positive aspects of having an advocate who's standing by your side, knows your story, and often can be that person that relates that story back. And 4 months into the test of change, we realised that we actually needed a female-only substance user worker, and that part-time post was funded by our Dundee Health and Social Care Partnership as well. And then further on in this year, in August this year, with the great support of Joan and Gwen, 2 local support fund managers from SDF, we managed to secure 2 years funding from CORA for 2 substance user independent advocacy workers. So the test of change had been in 18 months, and we knew that it was making a vast difference. But unfortunately, there was no specific funding within the Health and Social Care Partnership. And that's why we went ahead and approached CORA. We're currently providing support to specific support to 45 partners with substance use. We've got around 20 people on our waiting list. And cases don't tend to move particularly quickly because they are quite complex and have got a long history, and we need to unpick a lot of that. Some of the areas that we provide support in have already been mentioned today, but I will mention them again, is access to services, being listened to, or having a say in your care and treatment, adult support and protection. And something that maybe hasn't been mentioned today is about people with substance use that have families at risk issues. So that's through the child protection, either whether it's voluntary or on a formal basis. And that adds a real layer of complexity within a case that we support, where often these people have had their children removed but want to have them back and want to go on a recovery pathway to have success in that. We do support around housing, but we don't do benefits in Dundee because Dundee itself has a specific pathway for through the social work department for people with substance use. And that was set up by Neil Snedden and the Dundee Health and Social Care Partnership. More recently, what we have been involved in is the collecting of evidence of experiential data, and that has been a real, I guess when we started out thinking it was maybe just collecting that data and passing it on, but actually both advocacy workers have said it does allow that more in-depth insight into what our partners have experienced. It also allows us to look at, is there anything particularly within advocacy that we can change to help provide a better support? And we are also involved at local, strategic and national level at using that feedback to influence change. One of the things that we hear a lot is that how many surveys I've had to complete and what has changed. But we all really, really hope that the MAT standards, experiential data will make that change for people with substance use and their families. Whilst it is absolutely vital to have that trusted relationship with our partners, it is equally important to have that trusted and respected relationship with our professional partners. It's really important to allow us to be able to progress our referrals in a successful way, to have that relationship. And that's really challenging for advocacy workers when often the people they're supporting don't trust the professionals in statutory services or some other services. And it does take a while to build that trust up. And it's equally important that we ensure that we maintain our independence at the same time. It is important that professional partners actually understand what an independent advocacy role is, and what we can't do, because that often is a barrier as well. I've got a quote from, or a bit of a comment from Neil Snedden. He's no relation to me, who's integrated manager at Dundee Health and Social Care Partnership and also at Dundee Drug and Alcohol Recovery Services. And Neil says, from a Dundee perspective, something which we would like to encourage all other areas to consider is the importance of independent advocacy, in addition in supporting and enhancing professional relationships across. It's the real benefit which independent advocacy gives to its clients and families and carers. Independent advocacy empowers people to engage in their treatment and support. It supports people, be they the person presenting with a difficulty or indeed the loved one who spent years supporting the person, to articulate their needs, sometimes wants and sometimes wishes. We recognise that not everyone will need an independent advocate. However, for those who do, we really are seeing the benefits of this support and the person taking ownership of their support and indeed their recovery. Along with Neil, I am responsible for feeding in for MAT Standard 8 to our local ADP, who obviously feed that into Scottish Government. And we are looking at things like raising awareness with various elements of staff, whether it's statutory or not, and looking at places like perhaps things like pharmacists. So we've had some success when we haven't been able to contact some of our partners using the pharmacists, and that's been really successful. We're also aware we have a finite resources and advocacy service, and along with Neil, we're looking at using some digital resources to perhaps give people that maybe don't need an advocate in person, but just need a bit of that support around what would a meeting look like, what am I entitled to do, what are my rights, but really present them in an easy read way for people to understand. We are also involved in other aspects. So we're involved with the rehab pathway in Dundee, which is funded by CORA, and we will help people, and we are with you, ensure that they have if they want to make the right choice around what the rehab pathway will look like for them. And we're also involved with some of the other stuff that's going on with Health Improvement Scotland. And I think Freya maybe touched on it around mental health and substance use and dual diagnosis. There is some work in Dundee going on around that. There are some lessons, I think, to be learned for other advocacy agencies that would want to look to step into the substance use arena. And that's making sure that, you know, your staff, all advocacy staff need a level of expertise, but I've definitely found our substance use staff probably need to have a greater awareness of all the different services in Dundee. Also around, so we're looking at some job shadowing for them to do that. We also need to look at creating a pathway where that specialised input needs to maybe not need required, but they still need some advocacy support. So where do we have resource within our own organisation to be able to provide that? And one of the real important things for me is making sure that we have a really robust support for our advocacy workers, and making sure they have the correct trauma training, not to just support our partners, but also for them as well, because without them, we wouldn't be able to provide that independent advocacy support. A couple of other things we want to be able to do, hopefully within the next 2 years, is look at collective advocacy sessions to have a wider voice and feed that back, and also provide some advocacy support for families of people who had experienced a loved one with substance use. So advocacy, although it mentions about housing and benefits, is much wider than that. It crosses around, pretty much around across all the MAT standards, and is such a vital component in making sure that people have the right treatment at the right time for the right reasons.
Thanks, Mary. That was really helpful to hear the local experience, and we'll maybe come back to some of that detail in the questions. Can I invite everyone to come back on camera for the final session? And Austin, can I turn to you first for a question to the panel?
Sure. I think the first question is about capacity. So what's the caseload capacity of a worker, and then thinking that there might be 60,000 people with a substance use problem or a drug problem, and 30,000 of those may be in treatment. How many of those might require advocacy at any one time? And obviously there's a question of scaling this up. So how do we scale up capacity of services? Mary, can I maybe come to you first in terms of that one? I know obviously that you talked about the 45 people you're dealing with. So have you got a sense of that?
Yeah, I mean, both one of our workers is full-time, one's not, one's 28 hours. So that's 45 people across both of them, with 20 people on the waiting list. So what we're looking to do is, you can only do so much. You're never going to be able to, to provide advocacy for everybody. And that's why Neil and I are really keen to look at providing some resources that might be able to assist with that. I guess it's also about early intervention. So I think everybody spoke about that. If advocacy was available at the beginning of people's journey, less people, we hope, would go into crisis. And that's really when you've got really quite complex cases. So I think early intervention as well, and some additional resources would help. It's not the perfect answer, I'm afraid.
Thanks, Mary. Freya, do you want to comment on that?
Yeah, sure. I guess kind of it kind of sounds quite wishy-washy, but it also kind of feels quite blinkered to think about, okay, so we've got so many people in crisis, we need, like, how are we going to deal with it all? I think what's needed is a kind of change in perspective that we've not had in Scotland, I would say, or the UK. I guess as a society, I don't think we're quite rights respecting. Rights don't come into the conversations a lot, and the more that does, I feel like the less people, are not going to be in crisis, but we're kind of promoting more of a preventative approach. We're tackling kind of root problems like poverty and things like that. If we're really going to look at meeting people's human rights. The second part of that, and it might be quite controversial, is that, yes, I think kind of specialist advocates are great, but I also think that, people who are, staff who are within these services, I think they're already advocates for a lot of people. And I think kind of pushing more education and training within services to these same people, I think they can provide that advocacy ability, or kind of provide that voice if it's needed to kind of push a person's rights. We don't need to always have kind of specialized advocates or advocacy services that someone goes to, but rather we could train up people who are in these roles already to help. I mean,
I guess that could lead to a bit of confusion of roles. Maybe I could bring Rona in there on that.
Yeah, I mean, I think there's definitely lots of situations where someone can advocate for another person, whether it's a family member or someone in public services. I suppose for us, the independence of advocacy services is so important, because they don't have to have the best interests of the person that they're advocating for. They can really be there to make sure that a person's views are heard, when lots of other professionals have to have a best interest approach. That is their job, to have the best interests of the person in many different types of public services professions. It's a necessity for their job, and whereas independent advocacy can sit in that slightly different position, and often we find that the kind of conflicts of interest that arise when people are talking about their roles in public services mean that they can't advocate and to the extent that people from independent advocacy can. So I suppose that's something to think about within all of this. I think in terms of the wider question about resources, it's always a tricky one. I think referral pathways, because of where independent advocacy sits in different pieces of legislation, can be quite complex, and that obviously kind of contributes to what you were talking about, Freya, around people feeling like advocacy is exclusionary. And I think often that, unfortunately, is because it kind of is in a lot of ways, because of how it sits in legislation. Like, you have a right to access independent advocacy under the Mental Health Act, but not under certain other bits of legislation. So it does mean that it is narrowed down, and that's where the funding comes from those bits of legislation. For us, I think, is some really positive things happening in the policy world that obviously will take a long time to get into practice, but we've seen some fantastic recommendations from the Mental Health Law Review that is around opt-out independent advocacy. So that's really exciting, and hopefully will mean that there's better resourcing, and therefore more people can access independent advocacy. And I think thinking about referral pathways is really important. If someone sees themselves in a particular kind of box around drug use or substance use, it might be that they also have a mental illness and can maybe access independent advocacy in that different way. So I think thinking about where they can access independent advocacy and use the pathways to the best advantage is really important. And we're also looking at the upcoming human rights bill and how independent advocacy can fit into that, because that's another really important area that there is a lot of movement on independent advocacy, there's a lot of movement on human rights in Scotland, and we have a real opportunity to get independent advocacy into the upcoming human rights bill, which would be huge for independent advocacy in Scotland.
Thanks. Freya, you wanted to come back in?
Yeah, please. Yeah, no, I totally get that at the moment that advocacy, because it's only kind of mentioned in a few pieces of legislation, it feels quite exclusionary, but I feel like that's kind of the point of bringing it back to a human rights-based approach, because if we strip it right back to the Human Rights Act 1998, and especially Article 6 and Article 13, everyone has the right to representation in these decisions. And I think somewhere along the line, again, this might be controversial, I think that's been lost quite a bit, and it's made it seem like it's only available to some individuals. Whereas I think that going right back to the basics of human rights, I feel like everyone should be afforded the right to have their voice heard.
Thanks. I think Niamh is probably going to echo that point. Niamh?
Yeah, no, totally. I think what we're talking about here is really individual advocacy, and looking at how we advocate at an individual level, but thinking also of advocacy about how we use it as a way of systems change, because actually when we're getting to the complex cases, as Mary said, often what we're dealing with is really poor practices in treatment. So how do we change those poor practices? And I think from the capacity issue, I'm going to let Fen talk a little bit about the guide that we're working on. But one of the things that we want to do is try to capacitate peers to do the advocacy work. I am old enough to, like you, Dave, to remember the National Users Network in England and Wales, which was this amazing movement of people who were in treatment, who had lived and living experience, who themselves were providing that local advocacy support. And so one of the things we want to do is help to try and rebuild those kind of structures, whilst also having kind of professional, I suppose professional is the wrong word, because I would say people in treatment understand that system better than anyone, but people like us who can step in when it gets really kind of sticky, so that you're allowing that capacity to really grow. And what that does as well in terms of the systems change is it gives voices to how we change treatment systems, how we make them more inclusive, how we make sure that they're serving the population that they're meant to serve in the way that really respects their rights, really listens to their voice. So I think that there's that dual approach, that we need to bring people who use drugs, people who are in treatment, into this space in order to change the system and to reach the capacity that we need more broadly. And Fen can talk a little bit about the work that we've done around this.
Yeah, so what we've been working on is and actually, Mary, it sounds like you're having a similar thought of what to work on, is a guide to kind of train up people to advocate for their friends, their loved ones, other people, and have more of a, I guess, grassroots movement of regional advocates, so that it's not everything is on professional services. And like Niamh says, part of that is fundamentally a challenge to kind of how things are seen at the moment, because what I was saying earlier about like the devaluing of people's self-knowledge, it's really about valuing people who don't necessarily have professional qualifications specifically in relation to advocacy or around drug treatment or anything like that. It's about valuing just a basic understanding of this person is clearly in suffering, is clearly asking for this one thing, you're doing the complete opposite of it as a treatment service, that's wrong. And it's kind of just empowering people to be able to do that so that people can access local support. And also, I mean, one other thing is to try and level out some of the really difficult inequity that happens with release, where we are London based. And that means that although we do, like some of the cases I have, they're not all in London, but that immediately puts a limit where, because of the limited capacity, I can't be traveling around to different areas of England to help different people. And that does sometimes result in a different, probably, standard of advocacy. So if they can access someone regional, that would, I think, be really transformative for them. So the guide we've been working on is sort of digesting some of the guidelines for people, so you don't have to scroll through hundreds of pages, giving them sort of template letters that they can use, and just helping them really clearly see, okay, I'm at this stage, the service has said no to me about this, what's the next thing I can do?
Thanks, Van. Yeah, that's an interesting point. And going back to Niamh's point around the active user networks, and that's something we're actively supporting across Scotland. And it's quite interesting in terms of some of the responses to that, where there are lived experience groups, but people with living experience tend to find it difficult to engage with those. Obviously, we'd like it to be more collective, but I think that's the reality. So we've been funded by government to focus specifically on that. And I think clearly some of the challenges of that are the marginalisation of the population that we're talking about, that makes that seemingly much harder in the UK than in other European countries, sadly. But sorry, I'm not wanting to contribute that much as the independent chair of all of this, but I thought I'd add that. Austin, I'm conscious that we're running out of time already, which is sad, because we've had the most interactive session, I think, of any webinar so far.
Yeah, well, do we have time for a question? I mean, I suppose that the ambiguity about what's just been said is, how do we ensure, although it can be that loose and it doesn't have to be professionalised, how do we have a shared understanding of what actually advocacy is? Because we have different forms of advocacy, as has been said, but there's also that notion that there's a kind of broader advocacy for recovery, where people would model, somebody in who had their own lived experience would model recovery and work with somebody and advocate on their behalf, but actually be advocating for a treatment outcome that it might not be the immediate desire or need of the person. So how do we ensure there's a shared understanding of what, certainly in Scotland, this is an issue, there's a shared understanding of what advocacy is?
Rona, do you want to pick that up again first?
Yeah, I suppose it's what we would say, I think, is that there's different types of advocacy that can happen, and that lots of different types of advocacy are really valuable. Independent advocacy is a specific type of advocacy, and that's the type that we work on. You can get, family that do advocacy, you can get other professionals that can advocate within their role, but it's not independent advocacy. So for us, I think it's really important that some of that distinction is still clear, and that I was just looking at some of the other questions there. I think as many people trained in human rights as possible is always a good thing. You can't have too much of that, and all of that is going to improve people's choices, it's going to improve systems, it's going to improve services across the board. But I think, there's always going to be areas where it's independent advocacy that can be there in the best way for people, because they don't have that conflict of interest, they don't have to work in best interest, and that is very important when people might never be able to feel like they want to do what the system and service is telling them they should be doing.
Thanks. Mary, do you want to add to that?
There was this week was the SIAA conference, and that conversation came up in the room as well. So it's really quite interesting, is how do you make a simple statement that says what independent advocacy is. So there was quite a lot of conversation around it. So maybe there'll be something that comes out the conference that might be able to help, Rona. It is difficult because what you said is right, and it is basically that. But if you asked, people on the Dundee street, as an example, what's advocacy, they probably think it's somebody who goes about with a black gown and a wig, to be honest. So it is difficult. How do we raise that awareness?
Yep. Thanks, Mary. Niamh, do you want to come in on that?
I think Mary's covered it really well in terms of just really people understanding what their rights are, and really that goes back to what Freya is saying about how we make sure that this is premised on rights. And I think, yeah, from our point of view at Release, our work is really about dealing with people in crisis. And I think there are two levels here, and it's kind of that preventative advocacy where it becomes kind of ingrained within the system as to what, that as you enter a service, it will be expected that you will get a standard of care that is reasonable and that meets your needs, as opposed to kind of some of the work that we're doing, which is crisis advocacy, which is where you are absolutely at risk of having your medication withdrawn, having it reduced, like the level of crisis. And, I think there's a tension here as well about kind of legal rights, or not legal rights, that's different, but enforcement of legal rights and bringing a legal challenge, because that's a very long-term kind of solution. We've gone through, we did a judicial review recently of a group of patients whose diamorphine had been removed or threatened to be removed on the basis of policy and financial grounds. And we brought a JR, we got an interim order to keep them on their medication. We settled the case on the basis that there would be an independent expert who would assess their cases. And thankfully we won the case on behalf of the clients. But that took 3 years. And Mary, you made a brilliant point earlier about just people having to repeat their trauma over and over and over again. And so I think that the beauty of advocacy is that you are trying to deal with the situation in a quite quick period of time. And so I think it's really interesting when we talk about rights and we talk about advocacy and making sure that we're balancing that very difficult balancing act of managing people's expectations of what they can get within a time frame. And then also saying, but if we need to go to court, this is what this is going to be like. And that can be quite traumatic.
Okay, thanks everyone. I'm afraid we're going to have to bring that to an end. Sadly, that I'm sure we could have gone on for another 20 minutes, but thank you all so much for your contributions. So just to say that this webinar has been recorded and an edited version will be published on the SDF YouTube channel as soon as possible. The previous 6 MAT webinars are on the channel already, and the webinar on MAT 7 will be published next week. We will be sending out an evaluation shortly, and it would be helpful if you could complete that. As highlighted, this is the 8th in a series of webinars on MAT standards implementation. The session on MAT Standard 9 will run on the 20th of January. If you haven't yet booked for that and would like to do so, a link will be provided in the evaluation email. So finally, just a special thanks for you all for attending today, and particularly for the presenters, which I'm sure you'll agree has been a really informative session. Obviously, a lot of questions remain unanswered with regard to the implementation of MAT Standard 8, but I think we've covered a lot of those issues in a very valuable way. So thanks again, and goodbye for now. Thank you.